Thank you. I was not in these seats because Al Sommer hadn't built this theater yet. But I was here 35 years ago. And I do want to say, Tom, that having talked about my background, first of all, I apologize because if I was sitting there, as I was a moment ago, listening to this, I would already be bored. I will try not to bore you with the rest of my talk. But I also want to note that you mentioned the rival institution. I spent 12 years in academia. One of those years was here at Johns Hopkins. It was way better than anything else I ever did. So, and I met my wife in these classes. And we got married the week after graduation. Okay, so what are we going to talk about? First of all, President Daniels, thank you so very much for hosting this today, for speaking on behalf of global health. It's wonderful to see what kind of resonance global health has taken on since I was a student in the Department of International Health with, I would note, Keith West as one of my classmates at the time. The work that I've done, Tom mentioned the years in the field, but I'm going to start with that because I think what you do early in your career is particularly important. And when, in thinking about the title of this talk, the lasting impact that I was thinking about was a two-way impact. Not only an impact on the health and well-being of the world's poorest and neediest and sickest, but also the lasting impact on me. This experience here at Hopkins, the experience overseas, has a profound impact on me, and one that I try to bring back to my work in Washington, D.C., which often is not particularly responsive to the world outside the bubble of Washington politics. So let me talk about some of the lessons I've learned and how I would urge you to look at careers and work in global health. I have 5 rules. And they're pretty simple. Dive in the deep end, by which I mean there are an awful lot of people who dabble in global health, who tip their toe in the wading pool and get out quickly and then want to talk about their experience. When you sort of let go of that and just go for it, that's where you really learn, because you're at the end of a very long rope, and you have to figure out what actually is the reality in those places. Now, diving in the deep end does not mean that you should not first check the water temperature. I've had a couple of experiences where I forgot to do that, and I learned from that too, but I'm not sure I'd recommend that. Know what you don't know is one of the hardest things, particularly coming out of academia, where we are taught to know stuff, to be experts, to be able to make the case. And one of the things that I have learned most profoundly in my years in global health is a sense of humility, because generally the things that I thought I knew were wrong once I got to understand things better. I mean, there are some things that are sort of based on fact and data, but in terms of the realities of life and change in complex situations, you have to be aware that what you know, based on your academic training, based on your book learning, based even on your most recent experience, is a small sliver of the reality there. And unless you immerse yourself, again, going back to the deep end of the pool, you miss an awful lot. And some of the saddest situations that I know of in global health are people who thought they knew and just drove forward on that. Now, that's a little bit at odds with the next one, be stubborn. Being stubborn is persevering and taking the time to work things through, despite the fact that things are not working out very well. But not stupid, obviously. Some people are just stubborn for the wrong reasons. We know lots of them in Washington. I won't go there right now. But that stubbornness is what led Al Sommer to just stick with this dumb idea he had about vitamin A as a life-saving intervention, and to just grind and to prove his case to the point where this now is common knowledge that everyone says, well, of course, vitamin A saves lives. Well, that was not an automatic thing, and Al's stubbornness was directly involved. Check your values. I don't mean check your values at the door. I mean check why you are doing this from a value perspective on a very regular basis. And there aren't any values that are just the right ones for global health. I have a wide range of friends and colleagues whom I deeply respect, whose approach to global health is based on a wide spectrum of values. I mean, they're all good values, but there are different things that drive us for different reasons. And unless you're conscious within yourself of why you're doing this, you're going to wind up doing something that frustrates you, or that you then, after a long period of time, you say, why am I doing this? And I'll come back to this later on. And then finally, let go. That's almost a Zen concept. By let go, I mean don't be afraid to fail. And certainly in my career and experience, I've had some abject failures that were searing, but I certainly learned from them. It's a little bit like kayaking. You know, you've got to go with the rapids rather than trying to paddle against them. Have fun. Fun is an enormous driver, an enormous source of energy. I love what I do. I love what I did in Nepal and in the field. I love what I do in Washington, surprisingly. But if you can have fun with what you do, you bring energy and enthusiasm and passion to the effort. And then finally, in terms of letting go, understand that particularly in global health, we don't own this. It's not ours. It's really for and by those whom we have chosen to serve. And the most frustrating and difficult people I know in the arena of global health are the ones who own concepts, who own interventions, who own an approach to things, rather than sharing them, experiencing them with others, and then ultimately allowing those not to be theirs. So let me try to get through this in the time that I've got left, because I wrote a 4-hour speech here. So first of all, going in the deep end, I started off, this was me, in Bangladesh more than 35 years ago as a medical student. And that was really going in the deep end, because I had absolutely no idea what I was getting into until I got on a country bus and rode for 3 hours out of Dhaka with nothing but other Bangladeshis, not speaking a word of Bangladeshi myself, and fortunately was able to get off at the right place at a rural clinic where I worked for the next several months. Throwing myself into that was the most life-changing experience that I've had, and the reason that I'm here today. Going to difficult places included a year in Mali in West Africa, now famous for other reasons. This was the family that my wife and I lived with for 3 nights out of the week in rural Mali. You'll note that's 1 husband, 3 wives, 6 children. That was the family unit, and I certainly learned a lot about life in different circumstances and environments. Then in Nepal in the 1980s, going out to the field working, as I'll describe a little bit later, on childhood pneumonia. This place was a 5-day walk from the nearest road, twice a week flights into it. But by getting out beyond the end of the highway and out beyond the end of the power line and telecommunications, I learned immeasurably about what the conditions of life for a very large segment of humanity was like, and what we might be able to do to address it. And then more recently in Ethiopia, I now get to wear a suit when I go out. I'm sorry about that, but that's unfortunately the case. But still, the opportunity to get outside of the capital, which an awful lot of my colleagues no longer do, and see things in clinics and on the operating side of global health is a constant reminder of what it is we need to focus on. So you're here at Johns Hopkins, you're doing epidemiology, and you understand the data. So what about the data in global health? And I'm going to speak against type here, and I'll come back to why this is against type, but this is what has been talked about a great deal, and I have personally done a great deal of talking about this over the past several years. The growth and importance of non-communicable diseases, nearly 2/3 of annual global deaths. And the second point in this argument is that the vast majority of these deaths occur in low and middle income countries. So the obvious conclusion to this data is that we should now be directing our attention and resources to non-communicable diseases, right? That's what the data says, right? No. So let's look at this again, and I come at this from a value perspective. Looking at my own values, the reason I got into this and the reason that I stay in this is because I believe in justice and equity. I believe that those who have the least are the most deserving of our time, attention, and resources, and that needs to be where we focus our attention and engage. So you look at the world today, and this is no surprise to any of you, Sub-Saharan Africa, and then to a lesser extent South Asia, are the places with the lowest life expectancy at birth and the places with the greatest degrees of poverty. And then when you look at where people are dying early, that again is predominantly in lower income countries, 54% and 86% of deaths occurring under the age of 60. And so what about those places? Well, the data is different there. In fact, non-communicable diseases, while substantial, are not the drivers of that gross inequity in health and life expectancy in the world. It continues to be the same things that I studied here in the Department of International Health at Johns Hopkins, the infectious and reproductive associated causes of morbidity and mortality. So who are these people? They are children born into extreme poverty. They are children who are malnourished from a very early age, and they are across the world. And the inequities are reflected particularly in that development side of the spectrum. 4/5 of under 5 deaths in Sub-Saharan Africa and South Asia. Of the women dying every day, 99% live in developing countries. And the prospect of death as a direct result of maternal complications is vastly higher, 250 times higher in low-income countries than it is in high-income countries. So to my mind, those inequities are the ones that we most urgently need to address, and that's what I've spent most of my work life dealing with. This is a newborn child in Mali, and the challenges faced by newborns, I think, are well known to everyone here because you're global health students. So I'm not going to go into a great deal of detail here, but obviously the issue of breastfeeding is a critical one, and I'm pleased that there are as many nutritionists around here as there are. Early and exclusive breastfeeding, and this is a slide that some of you may have seen before. I did not take it. It came from Pakistan from the 1980s. 2 identical twins who, when the mother was advised by her nurse, was told after they were born, you are not going to be able to adequately breastfeed 2 children. You will need to start one on formula, decide which one is going to be on formula, and which one you will keep at your breast. Bad advice, bad public health policy, and one very sad consequence of the, at that time, aggressive commercial promotion of breast milk substitutes. The result at nearly a year of age is both tragic and self-evident. The smaller child, not surprisingly, did not survive much longer after this picture was taken. We also know that there's a wide range of diseases for which we have very good, very effective vaccines. This is a child with nuchal rigidity associated with neonatal tetanus. And as we all know, if we immunize mothers with tetanus toxoid, we can avoid neonatal tetanus. And yet, in some countries of the world, I'm not sure what happened here, but no, I don't. There we go. In some countries of the world, there has been an ongoing campaign against tetanus toxoid immunization, in some cases promulgated by conservative religious groups who have said this is really a birth control effort, don't get these shots. This was the case in the Philippines in the 1990s. And we come up against cultural and political influences a great deal in global health that are directly opposed to the health well-being of the citizens that they purport to serve. We've seen this in terms of some of the imams preaching against polio vaccine in some areas of Pakistan and Nigeria. We saw it with tetanus toxoid, and we certainly see it in the realm of family planning. These are areas where speaking truth based on scientific fact is critically important, but equally important is speaking with passion and conviction against political forces that have their own agendas that are not aimed at improving the lives of the people that they purport to be representing. Another immunizable disease here, we don't see much of this, well, we do see a little still in the United States, imported cases from measles. This is the sandpaper rash of measles, and a child with widely disseminated measles. And again, as public health students, you all know the severe consequences of measles, particularly in moderately and severely malnourished children. And of course, here we have the holy grail of vaccines. We talk often about the arena of HIV/AIDS, that if only we had a vaccine, all would be well. What kind of a vaccine would we want? Well, we'd want one that you could give once in a person's life and it would work forever. We'd want one that was at least 90% effective, and we'd want one that was cheap. That would be, we'd see the end of AIDS. Well, we've had that for measles for better on to 30 years. 95% effectiveness given at 9 to 15 months of age, and the cost of a single dose of about 12 cents. And yet, we still have close to 500,000 measles deaths around the world, not because we don't have the technology or the knowledge, but we don't have uniformly the political will to address it. And again, part of the global health mission becomes convincing those who have the power and the means to effect change that this is something that is needed to be done. This is, I might ask Al Sommer if he could identify this picture. I believe it's his or Keith's picture to begin with. I've extracted liberally without attribution from my friends and colleagues over the years, so forgive me for this. But this is a child, of course, with xerophthalmia. And as Al has shown, the simple expedient of providing that's an Indonesian child, I believe, Professor Sommer? Yes. The simple expedient of providing a high dose of vitamin A on a 6-monthly basis, in some places as often as 4-monthly, will not only dramatically reduce the risk of xerophthalmia and blindness, but as he has well proven, in spite of some recent counter-arguments, the impact on childhood mortality, as we learned ourselves in my project in Nepal, was dramatic, in the order of 26% from simply dosing with this 2-cent capsule. We're, of course, also still facing the global issues of diarrhea and dehydration. This child showing evidence of dehydration. And again, based on science developed in Bangladesh in the 1970s, we do have the extraordinarily effective technology of oral rehydration solution, which is now estimated to save between 2 and 3 million diarrhea-associated deaths, or prevent 2 or 3 million diarrhea-associated deaths per year around the world, and yet there's still between 1 and 2 million. So we're not there yet. This is simple, it's cheap, but it is not an uncomplicated thing to introduce into the societies, the cultures, and the economies where they take place. Just a personal reflection. When I learned about these things, I learned about them in a linear fashion. There is disease X, you treat disease X, and you've addressed it. But in fact, life, and particularly life in difficult circumstances, is far more complex than that. This is a particular case in point. This little girl I met in this remote area of Nepal back in the mid-1980s. Her name was Lakshmi. I'd walked 2 days from the district capital, the one that took 5 days to walk to, 2 days out into even more rural areas, and came across this girl in a village. She was breathing fast with a cough, and she was barely conscious. She was also 3 years old and weighed about 18 pounds. And it was obvious, we were in the process of developing a childhood pneumonia intervention in this area. It was obvious that she had pneumonia. And so we started her on antibiotics immediately. This picture was taken about 2 hours before Lakshmi died. You can intervene, but you can't always intervene successfully. We were trying to design an effective program that would work in very remote and difficult circumstances, like where this village was. And so we went back after her death and after the ceremonies had taken place, and with our local respondents, we did what's called a verbal autopsy, which many of you are probably familiar with. But this was a more in-depth verbal autopsy, looking at what we could glean from parents and neighbors in terms of what had happened to Lakshmi during the course of her life. And this is an extrapolation, so it's not real data. It would not be publishable in any of our accepted journals, but it is a reasonable approximation of reality, so I'll use it. Here's a normal growth curve. Here is what we extrapolated Lakshmi's growth curve to be. You'll notice that she was pretty much on track until about 6 months of age. What happened then? Well, a couple of things. One was that her mother got pregnant again. And when she got pregnant, her breast milk dried up. And Lakshmi was no longer fed by breast milk. She was fed by household food. No formula in this instance. This was an area that did not have commercial products. But nonetheless, no longer getting the caloric and nutritional value of breast milk. At the same time, at 6 months, she started crawling around and started getting into things, and of course had a number of things happen. So we then looked at what kinds of things had happened. Again, something of an extrapolation. And here are the various disease episodes. She had D for diarrhea, lots of diarrhea. The occasional acute respiratory infection, fever, diarrhea, just kept going and going and going and going. And then the big M, measles, swept through the village. And the last thing, the thing that we saw in the last 2 hours of her life was this acute respiratory infection. We treated her for that too late and insufficiently. But when you look at all the things that she faced in her life, it's obvious that there was more going on than just that episode of pneumonia. And what that teaches us is that we need to intervene at many different places. Now, what's interesting is that by doing one of those things, vitamin A in some instances, in our instance, what we did was develop a community-based pneumonia treatment program using health workers. This gentleman on the left is a trained health worker with all of 2 years of education, barely literate, but we trained him to do a couple of simple things. One was to count respiratory rate. This is a simple sand timer, 30-second sand timer, by which he could count how often a child takes a breath in the course of half a minute. Also looking for chest indrawing, which you can see a vague shadow on the chest of this child that's evidence of severe pneumonia. Those two simple signs obviously are not up to Johns Hopkins standards, at least not the Johns Hopkins across the street here. But what we were looking for was practical ways in the context of the resources and the personnel available to impact on what was and still is among the leading causes of child death internationally, and where there are no doctors, stethoscopes, working X-ray machines, bacterial cultures, but rather the most basic of opportunities to make an impact. And so once the diagnosis, the provisional diagnosis was made, we actually got approval from the Nepali authorities to have these health workers provide treatment with oral antibiotics. And over the course of 3 years, we saw, through a rigorous monitoring of mortality, we saw a 28% reduction in all-cause mortality, not just pneumonia mortality. This was a reduction in all-cause mortality. Now, why would that happen when you see in that earlier graph of the short life of Lakshmi all these other things happening? Well, we think there's not only a vicious cycle, there's also a virtuous cycle. In fact, we think most of the cases of pneumonia that were treated were cases that probably would not have led directly to death, but each one of those cases knocks that child for a loop physiologically, makes them more vulnerable to the next infection, to the next diarrhea episode. What that indicated to us is that even though there are lots of different things going on to affect the health of these children, and ideally we would do something about all of them, if you do some things right, you have an impact. If you do a lot of things right, you can have a huge impact, which is why we do believe that it's possible today to reduce child deaths to a small fraction of what they are, even with very limited resources around the world. Now, I mentioned earlier that you both have to be stubborn and you have to let go. It took a lot of time and effort to make this work, and then there was considerable resistance among medical practitioners who didn't like the idea of non-doctors giving antibiotics. We have clear evidence that doctors are among the worst providers of antibiotics, but we'll leave that for another time. In fact, we proved, and other programs elsewhere in the world proved, that trained community workers follow the protocol more rigorously, more reliably, and more appropriately than so-called more highly trained providers. And this was about a dozen years after we had published our article from Nepal. I was in the highlands of Honduras. Had to walk up a long, steep, and sweaty hill to get to the health clinic in this little village, and came upon this promotor de salud who had a higher level of education. I think he had passed 8th grade, but was working based on, you'll see this chart in the background here, what to do with children with difficulty breathing and cough. This is now the WHO and UNICEF standard, which is used around the world. I asked him what he thought of it. He said, oh, it's just making a huge difference in terms of the lives of children in this community. So this had spread over the course of a dozen years halfway around the world. And it certainly was not something that my fellow researchers or I owned. This was, at this point, part of common knowledge, part of what people do to help in the health services in their communities. We also know that technology and understanding of dynamics of disease makes a huge difference. This is a woman in Mali suffering from severe malaria. And malaria has been a real bugaboo for many years. Certainly during the time that I worked in Mali, it was so difficult to differentiate the fever of malaria from acute respiratory infection, from a range of other things. But now, over the past several years, we've come up, again, through the magic of research and technology, with a simple finger prick. Here's me getting mine in Ethiopia last year. And the blood test that told me that I was a control rather than someone with malaria parasite in my blood. I was grateful for that. So now that we have these tools, and there are similar tools, Gene Expert as an example in the area of tuberculosis, not as simple or as cheap as this, but nonetheless a major advance that allows us to understand with far more precision what people are suffering from and allow us to intervene more appropriately and effectively. So things are changing, and they're changing dramatically. We also know that insecticide-treated bed nets, like this blue net here, will significantly reduce the malaria burden in both mothers and their children sleeping under it. The men as well. Often one of the challenges of the malaria bed nets is that in many instances it's the men who take the nets because they don't want to be bothered by the mosquitoes. So the sociological challenge here and the marketing challenge is, do you just flood the community with bed nets so everybody gets one, or do you try to change men's behavior? Guess which one is easier? I'll come back to that. So Indonesia, 1970s, a newborn child, and clearly one of the things that we have learned in global health is that in reality it's women, and this goes back to the value of equity and social justice, women who pay the highest price. We know that there are in excess of 200 million pregnancies around a year around the world, and the vast majority in developing countries. This is an example. This was a two-family rooftop in this area of Nepal. Two families. I won't delay this long enough for you to get a count of the number of children, but there were a lot. And so we know very clearly, and I'm pleased to see my old friend Duff Gillespie here, who's been working on this for a very long time, that the unmet need for contraceptives is enormous, remains enormous around the world, and again, is something that has become a political football when in fact it should be a public health necessity. 47,000 of those women die from unsafe abortions because they did not wish to get pregnant and did not wish to remain pregnant. And close to 400,000 die as a consequence of pregnancy and childbirth. Now, we know that there, in addition to family planning, that there are some basic things that can be done to significantly reduce this risk. This picture on first look makes you think, well, this poor woman, this is not a good situation. Well, in fact, this is one of the more fortunate women from her community in Kenya because she is, in fact, giving birth in a health facility with running water and with trained healthcare providers. So it's not a matter of having it be fancy. The vast majority of obstetrical deaths can be dealt with relatively easily, and I use the word relatively with care here, but certainly do not require high-level intensive care hospitalization, but rather the presence of a trained delivery assistant and the possibility of cesarean section and a clean and sanitary environment. We know that, again, in terms of where this is happening, sub-Saharan Africa and South Asia. And we know a little bit about the dynamics here. Now, this is moving a little bit afield from the data of public health, but This was a picture I took in the hills of Nepal, and it struck me as symbolic of what I had seen and experienced in terms of the status of women. You'll notice who is not doing the heavy lifting in this picture. And in fact, you can't tell from this level of resolution, but the thing dangling by his leg is a transistor radio. The man had the access to the outside world, to communications, to the commercial sector. The women had access to the bags that they were carrying. We lived, my wife and I, and our 2 children lived for a while in Nepal doing language training. That's one of the languages that I claim, although I've forgotten most of it now. Language training in rural Nepal, and I would just note the respective sizes here. Our daughter, I think you can pick out which one is our daughter. Our daughter was 3 years old at the time this picture was taken. The little girl next to her was 5. My wife, who looks like she could be playing in the WNBA, is about 5'6". This is not because this woman and her daughter were genetically, biologically small. This was because from the first moment of their lives, they were the last to eat, the last to access resources, the last to get care. And this gets reflected generation to generation. It's particularly true in parts of South Asia, but it's also true in sub-Saharan Africa and Latin America. And it seems to be a very strong corollary to low levels of development. So you would think that the guys would wise up. Fortunately, some of the women are wising up. They are, in part with assistance from international groups and NGOs, banding together. This is a mother's group of Highland Mayan women in Guatemala who formed a mother's club. And the Mothers Club started demanding better healthcare services and access to family planning and nutritional services, and things started changing in their communities and in their health statistics. And certainly no discussion about global health in today's world is complete without a conversation about HIV and AIDS. And I could do a long talk about that, and I won't today, but the first exposure that I had to HIV was actually literally this photograph, this picture that I took when I was doing a nutrition survey in northern Haiti in 1982. And we saw this procession coming towards us, and I snapped a quick picture, and then afterwards, the people sort of trailing at the end, we asked them what this was about, and the fellow said, voodoo. And I said, what do you mean? He said, this woman's husband died after being struck by witchcraft, and he lingered for a long time and got thinner and thinner and had diarrhea, and then he died. Well, this was, as I said, 1982, before HIV had actually been characterized, but we were hearing about these strange voodoo deaths in increasing numbers throughout Haiti at that point. And of course, we all know at this point that this was the early surge of HIV in that country. This is one of Paul Farmer's pictures of one of his patients there who came in. Unfortunately, I don't have the follow-up after treatment because this is a patient who survived and is doing very well. But the wasting disease, slim disease, was the world that we knew through the 80s and the 1990s. And then inexorably, HIV moved into women, like this woman in Chennai in a TB and HIV hospital, and into children. We've seen enormous changes in the past decade, in part due to political activism of advocates and activists in the HIV/AIDS arena who did not accept the premise that because HIV drugs cost $20,000 a year, that it was impossible to consider providing them to people in low-income countries, and because they did not accept the premise that because the treatment regimen was complex and required multiple treatments with multiple drugs, that it couldn't be done in low-income, low-resource settings. This is one of the generic drugs that has been manufactured in India. We just heard about some news about generics in India that is something of an echo of this. But thanks to the dramatically decreased pricing of drugs and the extraordinary expansion of services based on both PEPFAR and the Global Fund to Fight AIDS, TB, and Malaria, we now estimate that better than 6 million people are receiving antiretroviral therapy, and we're seeing a change, a dramatic change in the curve of HIV and AIDS around the world that shows that even the most difficult things are possible if there is both political will and resources behind it. But the question remains, what about the girls? This, to my mind, is one of the most dramatic pieces of evidence in terms of the risks here. This was a survey done by the CDC in the early 90s in Kisumu. And you see here that by the age of 19, that about close to 10% of boys were HIV positive. But when they sampled the girls in the same population, they saw that as many as a third were HIV infected. Now, this was not those boys giving those girls infections. This was older men having sex with younger girls, sugar daddies. So again, we get into complicated cultural and social issues, but issues that we have to recognize and address if we're going to actually have an impact. These are young people in Haiti going through a training program on AIDS education, where they will then go out and teach condom use and safe sex. So I think the bottom line on all of this goes back to a quote that I learned a number of years ago. I believe it was in these very halls, that public health and medicine are social interventions, and that politics are public health in the most profound sense. It sounds like something that Bill Clinton might have said, but it wasn't. It was Rudolf Virchow in 1848, and it's certainly as true today as it was then. And that's what led me in the direction of Washington, in spite of the fact that I think you can see where I like being. But Washington is something of a long lever. I'm working now for Secretary Sebelius, the Secretary of Health and Human Services, who is absolutely convinced that global health is a necessary part of domestic health, that this is not something we do out of kindness or charity or goodwill. It's something we do to protect our own citizens against global threats and to make sure that we have global structures in place to address some of the major drivers of disease. But what about the data? Going back to what I said before, 2/3 of deaths due to NCDs, and still 90% of all premature NCD deaths and injury deaths do occur in low and middle income countries. So it's not that we can say, oh, we'll just deal with what I consider to be the unfinished agenda, the maternal and child health and infectious diseases. We have to broaden our scope. We're not simple-minded enough to say we can only do A and we can't do A plus B. On the other hand, we also are sophisticated enough that we've learned some of the things that we have not done a terribly good job on ourselves. Right now, and the reason that my department prioritizes non-communicable diseases in our global work, this accounts for more than 3/4 of American health spending, dealing with the downstream consequences of non-communicable diseases. Wouldn't it be nice if other countries didn't have to do that quite the same way we are? So when we look at the drivers, and I'll just point at one here, this was my first view of Nepal in the early 1980s. This is a chula, one of these clay pipes, smoking local tobacco that was grown in the field. The men would sit on their rooftop and have a bowl after, usually it was tobacco, after a long day at work. A few years later, we saw in the same community the first billboard. This is yak cigarettes. I'm not sure why you would want to call something yak cigarettes. Tastes like a yak. But nonetheless, this was the brand that of locally produced, locally grown tobacco. A few years later, we saw in Kathmandu the first of many billboards, Lucky Strike, an American original. So what this tells us is this is not just about local practice. This is about global forces and global commercial forces. Tobacco is, in many respects, the easiest one to pick on because there is absolutely no benefit to tobacco. It is the product that, if used as directed, will maim and kill. But in fact, we recognize today with globalization and the globalization of food products and beverages that we have to get our hands around how to deal with this before it kills millions and millions and millions of people in low-income countries. And as we've seen from the data, it is beginning to move very rapidly into the poor people, poor particularly living in urban slums, as it hits here in the United States. Finally, a woman along a trail in Nepal smoking a very nice Marlboro that I imagine some friendly tourist thought they were doing her a good service by providing. So let me end with the final thing that I said in my list of 5 rules. Let go. It's difficult for those of us who have come through academic institutions and training where having your name on papers and being recognized academically and advancing through your career requires a level of recognition to understand that if we're going to have maximal impact, it really does have to belong to them. We can help, we can certainly encourage, we can be facilitators, but as long as we own it, it will be washed away in the next social flood. So I would say that, again, going back to the core values, these are the people we serve. These are those who serve them, a group of midwives in Afghanistan. The picture taken, by the way, by your very own Carl Taylor, who is my professor and chair of international health when I was here. These are the hands and the eyes of global health, not the guy with the blue shirt. And ultimately, these are the people that we aim to make a difference for. Let me end with one final thing, which is, I said, have fun. I don't consider my global health career to be anywhere near done, but I will certainly look back on my years in Nepal, raising 2 little children there, living at home and doing global health instead of having to hop on planes, as one of the most wonderful experiences of my life. And my children remember it too. Thank you.
Great photo. Absolutely fantastic presentation and talk, and a whole history of your life reflected in memories and lessons learned in the field. It's absolutely fantastic. There is time before we go to Finestone Hall for the posters. Questions that folks would like to ask Dr. Daulaire? I'll start with one just to see if anyone else wants to jump to a microphone or shout out. So you went through several diseases very nicely in how we've addressed them. I sort of want to bring up polio because it wasn't addressed, and yet polio has significant morbidity and mortality. We've come so close, and yet we're still so far. I know CDC and HHS is very committed to this. What do you think, from your perspective, from what's taken place with other diseases, what our chances are, our opportunities in finally eliminating this particular scourge?
Well, I suspect everybody here is well aware that polio would become the second human disease eradicated after smallpox. D.A. Henderson, who was dean prior to Al Sommer, was instrumentally involved in that. Polio at this point is endemic in only 3 countries, but I'm going to go back 3 years to when it was endemic in 4 countries. India was the toughest nut to crack. It was a country where polio in the northern Hindustan belt of Uttar Pradesh and Bihar seemed impossible to eradicate because of all of the social factors that I talked about. Poverty, terrible sanitation, an environment where it was extraordinarily easy to transmit polio virus, and where the infrastructure and the capability and even the willingness of the healthcare system to do polio immunization was deeply in question. The Indian government took ownership, letting go again. This was not an issue driven by the United States or WHO. India made the decision about 5 or 6 years ago that this mattered to them. They have invested more than $1 billion of their own money into it. And many of us were deeply skeptical that polio could ever be eradicated in India, and said, well, you know, if you could do it in India, you could do it anywhere. Well, they did it in India. India has now gone, actually that photograph of Secretary Sebelius I showed you was her giving a polio drop to an Indian child on the first anniversary of the last case of polio, just over a year ago. So it's now been 2 years polio-free, and it's maintained. Based on that, and based actually on the dynamics that we're seeing, particularly in, interestingly enough, Afghanistan, where the number of cases this year has dropped dramatically, and where all reported cases have been imports from Pakistan rather than locally transmitted. We think Afghanistan is close, and surprisingly, in spite of the attacks on healthcare workers in Pakistan, the number of cases there has also dropped. There are still some very tough nuts to crack politically. Nigeria is the biggest challenge. It's not because environmentally Nigeria is that much more challenging. It's again because of both politics, political dynamics, terrorism, and the level of willingness of the government to do something about it. There's a mix of internal and external pressures at work, but cutting back to your question, do I believe that it can be done? I used to be a skeptic. I am no longer a deep skeptic. I think we still have to prove it, but I think it can be done. I think the mistake that was made 15 years ago was not putting enough emphasis into routine immunization systems, which I think would have brought us further along than we are today. But we are where we are, and we think in the next 2 years, it's likely that we'll see the last naturally transmitted case of polio. Yeah.
Absolutely. Okay, I see a few hands. So, Kelly, and then over here.
Great talk, thank you. And it's part of the challenge we're trying here at Hopkins, safe, scalable, and sustainable kind of taglines across many different disciplines. And for the scalable part, is some of the challenges we're working with. And I noticed that you brought up infant formula and tobacco. And what would you see, though, as a positive influence of industry, or perhaps the corporate side, in trying to translate public health into something that can go forward in a positive way to try to address this? And that kind of deals with last mile scalability.
Well, nobody does distribution better than private industry. I can get Coke and Heineken and biscuits and often tobacco products in some of the most remarkably remote places. So certainly some of the lessons learned from private market distribution systems, I think, are very important. And that's not only sort of learning what they did and then doing it ourselves, it's also piggybacking on the work that they do. It's an interesting balance because we recognize that some commercial products do harm. Some commercial products are neutral from a public health standpoint, and some commercial products are reasonably positive. But the bottom line is, if there wasn't a demand and a system for it, the good and the ill wouldn't happen. So we have to learn from that demand-driven and commercial sector-driven approach. We've certainly seen in the area of information technology, the explosion of cell phones around the world are absolutely staggering. In the most remarkably, actually, I can now call Jumla district in western Nepal. I could call them right now from my cell phone because they have cell phone service through significant portions of the district. And certainly in Africa today, that's a huge part of the commercial economy that has unquestioned potential for being positive for health. What we're looking to do with the private sector, particularly the food industry, is not to hold them up as the bad guys, but rather to work with them. And they've talked with us and said, we would like to do good. We'd like to do well, but we also would like to do good. One of the things that they have indicated a positive inclination for is some level of common standards. We might want to call it regulation, but often the private sector doesn't like that. But common standards in terms of sodium content, in terms of trans fats, in terms of sugar levels, that if everybody has to play by the same rules, they're not disadvantaging themselves in the commercial marketplace where, sadly, our hunter-gatherer genes say that we want salty, sweet, and fatty things.
Question right there.
Hi, my name is Mahmoud Durrani. Thank you very much for speaking. I'm a medical student doing my PhD here, so it's really great to kind of see the endless opportunities available to me. But I wanted to ask, you showed a picture of a lady in a healthcare facility that was there to give birth. I guess my question is, a lot of people are saying that, childbearing and childbirth, is becoming medicalized. What is your opinion on that? And do you think, and have there been studies out there that show whether women who give birth in a healthcare facility have better health outcomes than people who give, have their babies at home in developing countries?
The short answer is yes. There is very clear evidence. Now, this is not to say that every single woman, again, as you're training as a medical student, as I did some years ago, and we are taught to individualize by the patient. There are many individuals who will do perfectly fine with giving birth at home. But what's difficult to know is which ones are going to go bad. Most of the difficult deliveries and the maternal consequences, the majority of those are not predictable ahead of time. They're things that happen in the process of labor and delivery. And having a trained health worker available. Now, ideally, what you're going to have is as natural a birth as possible in a facility, but with someone available for rapid intervention. But when you're 3 hours away by ox cart in a village from the nearest health facility and something goes wrong and you start to hemorrhage, you're in very deep trouble. So unfortunately, we can do it right, or we can do it the way we're doing it here. But if we do it right and we make sure that there's a responsive system without making 40% of our childbirth cesarean section or elective early delivery, then we in fact improve the survival and the health of both women and babies.
So I'm going to have to draw this to a close. It's 1:30, and I know some have classes to go to. But I want to invite you all to Feinstone Hall now. We have 70 posters up. The students have worked hard to put these up. It's available all afternoon. At 4 o'clock in Feinstone Hall, we will give out awards to the students who have labored to put tell their story about their travels in the reflection of their posters. We will also have some oral presentations from the students as well. And so I want to welcome everyone to there, but I also want to thank Dr. Daulaire for a fantastic presentation and for spending the day with us. If you have questions, he's going to be with us for the rest of the afternoon, both in Feinstone Hall and then afterwards, open to faculty and students for open discussion. He can tell us all about Congress and the Global Health Initiative and how things are really working down in Washington. And there is supposed to be pizza in Feinstone Hall. So if you're hungry as I am, please join us next door. So thank you very much. Nils, that was great. That was wonderful. Yeah. We do have a